Respected senior colleagues and dear postgraduates, good afternoon and a warm welcome to you all. On behalf of IIDVL Andhra Pradesh, we are conducting these PG clinics once in every month. Our aim is to inculcate and improve clinical skills among the postgraduates in dermatology, venereology, and nephrology. This is our third consecutive PG clinic, which is taken up by Professor Dr. K. Sitaram sir, HOD, DVL Department, GSL Rajahmundry. Thank you, sir, for volunteering. Sir is our internal examiner for today, and we have a very privileged and distinguished faculty as our external examiner, Professor Arun Inamdar, Professor DVL, Pro Vice Chancellor, BLD University, Bijapur. Thank you, sir, for accepting.
Namaste.
Our presenters for today are Dr. Dhriti Chak and Tanuj Reddy. I wish you both all the best. And now I request our President, Dr. Atota Kavita, to give her presidential address.
Good afternoon. A warm welcome to all of you for our third PG clinics. And it is indeed a great honor for us to have with us the teacher par excellence, Dr. Professor Arun Inamdar sir, who is well-known master in pediatric dermatology. And I thank you sincerely, sir, for external examiner for today. And our internal examiner is none other than Sitaram sir, who is the backbone of IIDVL Andhra Pradesh and who is our mentor. And we are lucky to have both of them as our examiners today. And it is a great academic feast for all the postgraduates, and wish you all a happy learning. Thank you.
Thank you, madam. Now I request Dr. Subhashni, Associate Professor of GSL, to take over the proceedings.
Thank you, ma'am. Good afternoon, everyone. Once again, welcome you all to another exciting session of PG clinics conducted by IIDVL AP on connective tissue disease. It gives me an immense pleasure to introduce our renowned external and internal examiners. To introduce Professor Arun Inamdar sir, who is our today external examiner. He is a professor of DVL and Pro Vice Chancellor, BLDE University, Bijapur. He is a teacher par excellence, excellent orator, and sir presents difficult topics in a very easily understandable, simple way. And he is an innovative researcher with numerous publications and several books to his credit. Pediatric dermatology and critical dermatology are sir's passions. Bijapur DVL department is one of the first colleges with a critical care unit in the dermatology ward. At BLDE, pediatric dermatology fellowship is available. Lately, they are planning to start fellowship in lasers with experts from India and in association with DEKA Italy. Sir has conducted recently a webinar on lasers under BLDE DEKA Laser Academy. Sir, we are extremely happy and fortunate to have you in our PG clinics today, sir. Thank you, sir.
Thank you.
And we are extremely happy to introduce our Professor K. Sitaram, sir, who is our internal examiner. He is a professor and HOD of DVL Department, GSL Medical College. Welcome you, sir.
Thank you.
Our final year postgraduates, Dr. Dhriti Chak and Tanuj Kumar Reddy, are going to present the case. And I request all the delegates to post the questions in the chat box, which will be answered at the end of the session. Now over to the presentation.
Sir, just one question to Dr. Sitaram, sir. In between also we can ask the thing, no?
Yeah, wherever.
Definitely.
Stop wherever in the history.
It would be better.
So
Right.
the idea is only to learn. So it's
Yes.
make them learn today. That's it.
Yes.
Whatever, wherever you want to stop, you stop it. Everything.
Yeah.
Just take it as a normal thing, routine.
Yes, sir.
Sir, your voice is a bit low, sir. Sitaram, sir.
Nada?
Sir.
ఎలా సరే చూస్తాను ముందేమో.
For me, it's okay. Probably.
Now it's fine, sir.
Yeah.
Okay.
Good afternoon, everyone. Myself, Dr. Dhriti Chau.
Myself,
Echo.
Dr. Tanuj Reddy. Now we will continue the case present. We will begin the case presentation. A 22-year-old female resident of Rajahmundry, who is student by occupation, came to our OPD with chief complaints of red color lesions over face since 6 months, fever since 6 months, reddish lesions over hand since 5 months, pain over knees and finger joints since 4 months, oral ulcer since 1 month. History of present illness. Patient was apparently all right 6 months back. Then she noticed red razor lesions over her cheeks and nose. After 1 month, lesions got aggravated to involve forehead, upper lip, and hands. These lesions associated with burning sensation, which increased on exposure to sun. History of low-grade on and off fever was present throughout the course of illness since 6 months. Not associated with chills and rigors, subsided on oral medication. Patient also complained of pain over knees and finger joints since 4 months, associated with morning stiffness, restricting her daily routine work. Not associated with any swelling or deformity, aggravated during the episodes of fever. Painless oral ulcers was present since 1 month. History of easy fatiguability present, and history of diffuse hair loss present. History of prior drug intake.
Okay. 1 minute.
Yes, sir.
You are told now it is the negative history you are going to talk.
Yes,
So
sir.
whatever history you have accumulated now, starting from the history of present illness and some more histories.
Yes,
For example, what I wish to tell is how history is directing you to a certain group of disease or collective symptoms which are trying to tell you that, okay, I am so and so. Is there any evidence? Go back to the first slide, then come back. Okay, in this,
yes, sir.
gist of this came to OPD with chief complaints. Do they spell anything?
Yes, sir. As red color lesions, fever since 6 months, and oral ulcers will lead towards the connective tissue disorders, sir.
Not
Will-
exactly. The
Yes, sir.
multi-system
Joint.
involvement is seen
Yes.
here, isn't it?
Yes, sir.
Fever is there, then some lesions over the sun-exposed areas,
Yes, sir.
and joint pain is there, and then oral ulceration. So, though you know the diagnosis, but initially for anybody who wants to say that, okay, we are dealing with some disease, group of disease, anything which comes with a multi-system involvement, probably you are right in thinking collagen vascular disease or connective tissue disorder, which we used to call earlier. Now it is more of collagen vascular disease. Next slide. In this history of present illness, what do you take out?
Sir, as red razor lesions over cheeks and nose present, no, sir. We think.
So the last one, which I
Photo
made it in a red light,
Yes, sir.
red associated with burning sensation,
sense-
which
photo
increased
sense-
on sun to sun exposure. So what does it speak?
Photosensitivity was present.
Okay, and you have an adjunctive called burning sensation. Okay, if it have to be more of itching,
Yes, sir.
does it speak any other disease?
Can be PMLE, sir. Polymorphic lighter.
Okay, itching is one thing what's commonly over the sun exposed areas. Think that we are dealing with collagen vascular disease only. Burning sensation on exposure to sun and itching are more pruritus on exposure to sun. Does it give a clue for any other collagen vascular disease?
Rosacea and dermatomyositis.
Yes, dermatomyositis also has a photosensitivity, but more of itching and other things. Okay, of course, itching can be there in the photosensitive rash or malar rash of SLE. But what I want to highlight in this is how history can take you to a particular subgroup of disease which we want to deal with, or a group of disease, and then you, by gradually going for next, what you are going to do is the negative history. All these things are positive history, isn't it?
Yes, sir.
Positive history, why you are going to negative history? Already you know that, okay, probably I am dealing with this. So I want to rule out other conditions or the other causes or other symptoms of those things by asking those negative history. Okay, next. Oh, here also. Go back. Go back. Go back. Yes. Here also. Next. Here also. The another symptom with which the history is pain over knee and finger joints. About a 4 months duration. That means it has ruled out. We have ruled out the post-viral or infective causes, so that it is there for almost 4 months. And the very typically both finger joints and knee joints are also involved, and they are associated with morning stiffness, which is again suggestive of some collagen vascular disease, not associated with any swelling or deformity, probably not a very severe collagen or the prototype of collagen vascular disease like rheumatoid arthritis, and aggravated during the episodes of fever. Well, this cannot become very much a point in favor of anything except any viral fever which can come with that. So even these type of histories are also very important to come to some conclusion, because though we do not deal with rheumatoid arthritis per se, but you must know what type of the joints are involved, whether symmetry is there, asymmetry is there, joint swelling is there, or deformity is more common in those diseases or the other group of disease which we deal often, isn't it? Next.
Yes.
Here also there is very interesting. This is exactly what I did not want here. The painless oral ulcer was present in 1 month. History is, have the patient told, when it is painless, most of the time, if our diagnosis is what you are contemplating, usually patient will never say. It is the finding which we as a physician try to find out. So in history, it may not. On examination, or I found something of that kind should have come. Anyway, okay. And most important thing, easy fatigability and diffuse hair loss. They're very important common presentations of the group of disease which we are going to deal, collagen vascular disease. Sometimes it is so that the fatigability and diffuse hair loss will point out, and sometimes we do ANA, and you know the rest is a different story. So as far as painless oral ulcer was present since 1 month, I don't know whether Professor Sitaram will agree with me or not. Should we write in history or not?
No, if they say that I have oral ulcer, we can say, we can mention it. If they don't say, it's fine, because it's only a complaint. We are talking
Yeah.
about.
Yeah.
Yeah.
Basically, it is, as it is a painless, many a times they will never say.
Yeah.
So that's
Actually,
the
sir,
crux.
on oral ulcer, we asked them if it was painful or painless. On examination, we looked for tenderness, sir. On history, we just asked if it is painful or painless. So she told like it was painless.
Doctor, if it were to be painful, definitely patient to tell I have got something in oral cavity also, isn't it? Unless it is so extensive, acute, bullous, or a type of like LE with the other syndrome which we call where EM-like lesions, oral mucous membrane is severely involved, those things. I'm just giving you, see, it is not exactly what is expected in examination. I'm trying to add to it. Okay, right. Now go for the negative history.
No negative history of drug intake prior to onset of lesions. No history of breathlessness, chest pain, palpitation, or hemoptysis. No history of frothy urine, burning maturation, hematuria, decreased urine output, or swelling over the limbs and face. No history of difficulty in eating and swallowing. No history of nausea, vomiting, diarrhea, or abdominal pain.
So why did you take each one? Go back. Don't be in a hurry. Nothing will happen. So why did you ask no history of drug intake? If it were to be like what drug did you ask? Why did you ask breathlessness, chest pain, palpitation? Why did you each one you should substantiate? Why you should ask?
Sir, certain anti-ATT drugs like isoniazid will cause the connective tissue disease, sir. And anticonvulsants like valproate and phenytoin can cause the disease. Antifungals like terbinafine, griseofulvin can cause, and antibiotics like penicillin group of
So
drugs.
you want to allow drug-induced lupus
Yes,
erythematosus,
sir. Yes, sir.
PIL. Okay, which is the historically the first drug to be described as a drug-induced lupus?
Hydralazine procainamide.
Okay, good. Next one. Why
Sir,
did you ask?
we want to rule out involvement of lungs and cardiac systems, cardiovascular systems. As it is a multi-system disease, we want to rule out involvement of lungs.
See, it is all the covers like pleural cavity, peritoneal cavity. Those are, or pleurisy has to be, those are involved. So directly you would like to ask breathlessness, chest pain, palpitation, or hemoptysis, or pain during breathing, or sudden, I mean, those things should have been asked, I believe. Okay. Next. Why frothy urine, burning, all those things?
Sir, proteinuria will lead to frothy urine, sir, because of involvement of kidneys.
Okay. There's a good point I would like to tell you is the morbidity or mortality in supposedly SLE, which you are thinking in this, is due to renal involvement. So you want to ask these things. That should be a primary motto, isn't it? Next. Difficulty in eating and swallowing.
Yes.
Why did you ask?
Sir, to rule out other connective tissue disorders and GI involvement.
All these things, all this time, probably you are thinking by history and negative history, something like SLE. So why should you ask difficulty in eating and swallowing?
Systemic, to rule out systemic sclerosis, sir.
All of a sudden, how another disease you would like to think as a collagen vascular disease? So
Sir,
is there any other way?
Sir, in case of MCTD, multiple connective tissues disorders can be.
I got it. MCTD. Why in the age of the patient? Is favorable to MCTD or not? Yes. Younger age, and all the MCTDs are tagged with systemic sclerosis plus other disease. So systemic sclerosis is a main trunk. All those whatever roots or the different things are added would be always like that. So that's why you are asking. Next. Why this? Just like that nausea, vomiting, diarrhea for everybody.
Sir, GI involvement.
What way GI involvement is seen in the collagen vascular disease? Name one.
Sir,
out of commonly what we see.
Some mesenteric ischemia, pancreatitis, and hepatitis can occur.
As a dermatologist, I don't think we'll see much. But anyway, my idea is not to add any history, which is just like that, everything to be added. Okay, sometime it's fine. Next. So you now know why you should ask negative history also. Probably you are trying to add to the symptomatology so that you are trying to rule out those things, and any of these collagen vascular disease or syndromes or certain inflammatory disease, every manifestation will not be there at a given time. So over a period of time, they may develop. So that is why this negative history every time is a must. Next.
No history
why
of
headache? You should always supplement. Sir. I mean, prove your why you are asking.
Sir, CNS involvement will be seen in systemic lupus erythematosus.
Okay, next.
To rule out, yes, sir. Bluish discoloration and exposure to cold or ulceration over fingertips. To rule out Raynaud's phenomenon.
Okay. How do you ask in Telugu? This bluish discoloration, exposure to cold or ulceration of the finger to a common patient. You're just telling what bluish, they will not understand.
We will ask about
what
tingling
is the best
numbness.
Question to ask?
Tingling numbness, whether patient will feel.
Telugu.
Telugu,
Sir.
you are Mr. Reddy or the other?
Yes,
Girl?
sir. Reddy's.
Tell me.
Uh,
How did you ask?
చల్లని
Water?
వస్తువులు పట్టుకుంటే చేతులు తిమ్మిరిగా ఉన్నాయా లేదా అని అడుగుతా.
Only when extreme cold do you feel like that, or
Yes,
after working over a prolonged period in cold water do you get these type of things. It is not that suddenly they will experience bluish discoloration and tell you like the Western books, isn't it? So you should
yes, sir.
know how do you ask that history also. So extreme cold exposure, or over a period of time, long time they have worked in a cold this thing, and what
Yes, sir.
occupation they do, even that also will give you, isn't it, history. So you should know how to ask that type of history also. That if you tell no blue sir, it become red, then it's not a wrong answer. Okay, next, tightness.
Yes, to rule out
Okay, next.
skin thickening. Yes, sir. Difficulty to rule out myositis, dermatomyositis, proximal muscle. Pain in calf muscle to rule out applus in thrombosis in the deep veins, sir.
I don't think you get such type of things. Okay, difficult in those is okay. Dryness in mouth and eyes, that's fine because you want to rule
Yes,
out
sir.
Sjogren's. But
Sjogren's.
anyway, sometime history, it doesn't mean that. See, in the very first 2-3 slides or the history, whatever you have taken, it is directing to particular group of, though collagen vascular, you are trying to make it one particular disease, and you want to rule out others because MCTD has to rule out considering as younger age. But
Younger age.
extreme things like the pain in calf muscle, all those things may not be necessary. But all the collagen vascular disease, people can go in for thromboembolic phenomenon. Well, you have a, okay, it's fine to ask. Next.
Past history, no history of similar complaints in the past, no history of tuberculosis, diabetes, hypertension, thyroid, epilepsy, ischemic heart disease, drug allergy, no history of hospital admission for the same or any other medical or surgical illness. Treatment history, history of usage of over-counter medication for fever, history of application of topical steroids for face with no improvement. Family history, no
How
history of
does it
similar.
help? Application of topical steroid for face with no improvement.
Sir, in polymorphic eruption, light eruption, there is improvement will be seen after taking topical steroids.
Okay,
for
if the patient keeps on applying topical steroid over the lesion, and then he will develop more erythema, more redness. Whenever he goes in sun, it becomes more red. The topical steroid abuse syndrome or destroyed face, whatever you call name, then isn't it?
Topical steroid damaged face. But
Rosacea, steroid rosacea on exposure to sun can also become red. Well, there are other findings by which we can differentiate. Next.
personal history,
No, family history. Don't skip.
no history of similar complaints or any other chronic illness in the family.
Are there any familial collagen vascular diseases? Is there anything like if parents are suffering, they will also suffer?
Monogenic lupus,
Okay.
consanguineous
Next.
marriage.
No, that is okay. Next, personal history. It's
Personal
fine.
histories.
Don't worry about that.
Okay.
Menstrual history. Why it is important?
Sir, because of estrogen can aggravate the disease, so
that's why females are getting more collagen vascular disease. Okay, if she married or unmarried?
Unmarried, sir.
Okay, if she is married, how this obstetric history would be important?
Sir, menstrual irregularities and
risk
that is
of-
important, or other obstetric history is important if she is a
Sir,
married young
obstetric
girl.
history we will take if we'll suspect neonatal lupus, risk of in pregnancy there will be risk to both mother and fetus.
No, I will give a
And-
clue. History of repeated abortions.
Aplas
Aplas
syndrome we will
syndrome.
suspect, sir, in case of repeated abortions, and in
So
case of history of
that history
thrombosis.
would be more important, and peripheral, the other things would be different thing, gangrene and other things. Okay, right. Next. Okay.
Coming
What
to
is
the
positive? No. Just tell me what is positive in general examination and how they
So,
are important.
So Pella was present in case of in our case, and it is important because in case of systemic lupus erythematosus, we see pancytopenia with decrease in all
Okay. Next,
hemoglobin.
anemia. Next.
Edema was present over the eyelids. Edema
Mhm.
can be a positive factor in case of albuminuria, which is seen if renal system is involved. So albuminuria
Okay.
present
Did
as
you
edema.
ask? 1 minute. 10 minute. This edema or eyelid,
Yes, sir.
any diurnal variation is important, or when it appears is more important. Whether the edema of both eyelids are more important or only upper eyelid is important. In what way all these scenarios can be explained by you?
Edema can occur in conditions like renal involvement also and cardiac involvement also.
No, how renal involvement edema differs from cardiac edema?
In renal involvement, we'll get morning edema, sir.
Very good. Next.
In cardiac involvement, edema will be more on lying down.
Okay, leave it. Renal we want early morning, and
early
as the day
morning.
passes,
It
the
will
edema
subside.
comes down.
Mm.
I am asking you if it were to be only edema of the upper eyelid or a bluish discoloration, what do you think?
Dermatomyositis we should suspect as periorbital inflammation and edema is more common.
What is it called as?
Raccoonicine in dermatomyositis.
Raccoonicine is in children.
Heliotrope. Sorry,
That
heliotrope.
there will be bluish discoloration, and only upper eyelid will be most of the time involved, not the whole one.
Yeah.
Okay. Right. Next, temperature. Why you written in red?
So fever is the main is one of the criteria to assess the prognosis, to assess EULAR criteria to
Okay,
assess
later.
systemic
Criteria.
lupus
Okay.
erythematosus.
Right. Next, we'll come back to that. Next. So, what was positive in this systemic examination? Nothing.
Yes, sir. Respiratory system, cardiovascular system, CNS was normal. Per abdomen was also normal, and
What did you
musculoskeletal.
do? What CNS manifestations?
Sir,
No focal neurological deficit you are written.
yes, sir.
What do you get?
Patient was conscious and well oriented to time, place, and person. We should rule out delirium, psychosis, and seizures. So
CNS lupus psychosis is more common than the
yes,
other
sir.
thing.
Yes.
Okay. Then we have written, but you have written focal neurological deficit.
Yes, sir.
Neuritis, you get multiplies.
Yes, sir. Seizure, psychosis is common.
Okay.
Neuritis.
Okay.
If vasculitis happens, we can get focal neurological deficit in case of if CNS
Next.
small vessels are involved.
Next. Okay. Next, that only cutaneous.
Coming to the cutaneous examination part, multiple symmetrical erythematous papules and plaques with mild scaling and ill-defined borders were present over bilateral malar region and dorsum of the nose, forehead, brow areas, upper lip, and chin. Nasolabial fold and retroauricular areas were spared, and there was no ulceration over the lesions and rest of the face.
Okay, what is obvious in this? Go back.
So
there is a rash,
yes, sir,
which is over the face
malaria
in the malar area,
yes,
in a
sir.
butterfly distribution, isn't it? And
Yes,
you want
sir.
to tell that there is a sparing of nasolabial fold
and
also. Okay. Next.
Palms, discrete erythematous, blanchable macules, mostly on the palmar surface of the fingers, were seen. The proximal interphalangeal joints and knee joints were tender, non-swollen, with no visible erythema or deformity. There were no lesions over other phosphosensitive areas of the body. There was no digital scars or ulcers and no atrophic scaly plaques over scalp and ear. Coming to oral mucosa, single non-tender erosion of size 1.5 into 1.5 centimeter with surrounding hyperpigmentation was present over the hard palate. Erosions were also present over the lower lip.
Okay.
Talp,
Okay.
diffuse sparseness of
1 minute. Go back. Start with the first. Okay, you have got a malar rash. What is it called as? Malar rash.
malar rash.
Butterfly rash.
Butterfly
Isn't
shade
it?
malar rash.
So, how this butterfly rash is different from the butterfly rash or the rash over this sun exposed area of dermatomyositis?
Sir, in dermatomyositis, nasolabial folds will be involved, whereas in systemic lupus, nasolabial fold will be spared. And here, malar region is more commonly involved, whereas there we see peri-orbital involvement, and it will be pinkish violet in color in case of dermatomyositis.
Okay, those colors are all like depends on the type of skin which we are going to deal. What is the definition of malar rash?
So, symmetrical erythematous maculopapular rash present.
Is it fixed erythema or?
Yes, sir, it is a fixed erythema.
That you have to start with the word fixed erythema over the area, isn't
fixed
it?
Erythema, symmetrical fixed erythema present over bilateral malar area, involving the sparing the nasolabial fold. Sparing the nasolabial fold.
Okay, next. Go to next. Okay, what do they reflect? Discrete erythematous blanchable macules mostly on the palmar surface of the fingers. What type of these lesions?
So these are erythematous macules.
Are they due to vasculitis? Are they due to just telangiectasia? Are they specific skin manifestations of the SLE, or are they non-specific skin manifestations of the SLE?
So these are non-specific skin manifestations which can be seen in other diseases also, like systemic involvement in case of liver disease like Wilson's disease.
No, don't worry. I'm just asking you. I just want to know.
No, sir, it is
a
not
non-specific skin
manifestation. Many other conditions we can find it.
Next. Go to next. Okay. Okay. What is the difference between you have written PIP and knee joints were tender, non-swollen with no visible erythema or deformity? What is arthritis and only arthralgia?
Sir, in arthritis, deformity will be present, whereas in arthralgia, only pain will be present.
Pain and swelling can be there.
Pain and swelling can be present.
Okay. Right, next. Okay, coming to this. What is the importance of this oral mucosa ulceration?
Sir, it indicates. Sir, oral mucosa involvement indicates active disease, and it is also a criteria for systemic organ involvement.
Okay, so whenever you get an extensive lesions, even in, for example, disseminated DLE, if you can find just one oral ulcer, you should think that patient is going in for SLE. Where else you can get this oral mucosa ulcers?
Oral mucosal ulceration
other than this oral mucosa, this type of ulcers, non-tender ulcers or erosions, where all you can get it?
Sir, oral mucosal ulcers can be seen in case of lichen planus.
Madam, 1 minute. Oral ulceration is an oral ulceration only. I am asking you, if it have to be SLE, which we are thinking now, in SLE, this type of ulcerations or these things, where all you can get?
Sir, mainly we'll get in hard palate, sir.
One is hard palate. That is very specific of a thing. Where else? Any other area you know?
Yes,
No,
sir.
you
Over
have not.
buccal
no.
mucosa also,
I will-
lips, soft palate
No.
also.
I will tell you. You have not read. Even in nasal mucosa, even in vaginal mucosa, you can
Yes,
get.
sir.
But
All
the hard
mucosa.
palate erosion is the specific one. Even some people used to consider the nasal ulceration also, which we do not see often. The today's learning is whenever you find oral erosions like this, please look into the nasal, and also if it is a female, the vaginal, are there any ulceration like this? Okay.
In mucosal DLE, sir, we will find DLE, nasal, conjunctival, and
Next. Okay.
scalp, diffuse sparseness of hair was present. Palms, palmar erythema was present. Soles were normal. And in nails, ragged cuticles were seen. Genital mucosa was normal.
Okay. Actually, ragged cuticles are seen in which
So
collagen vascular
dermatositis, it is more common.
Did you do capillaroscopy of that?
Yes, sir, we did nail fold capillaroscopy.
No. Later we'll discuss. I'm just asking you.
Yes, sir,
Okay.
we did.
Next.
On nail dermoscopy, splinter hemorrhages and rat cuticles were seen. So, considering the history and clinical examination part, our provisional diagnosis, which we considered, was systemic lupus erythematosus.
Okay. I will give a chance now. So when you make a diagnosis, provisional diagnosis, how did you make? By history alone? Very few points by which, okay, I am dealing with SLE or a collagen vascular. And by examination, how did you make diagnosis?
Sir, in history, first patient complained of photosensitive rash over the face. This was in favor. And joint pain, she complained of joint pain, which
No, I have told you already. Multi-system presentation was there. It's more
Yes,
important word.
multi-system
Okay.
presentation was there.
Then it was for a prolonged period, about 4 or 5 months, no?
Yes, sir.
It's not 1 week or so. Next.
Multi-systemic involvement was there, cutaneous involvement was there. On examination also, we saw oral ulceration, which which were painless also, so which showed it to be
The
a feature
patient
of
had very classical photosensitive rash,
photosensitive rash,
otherwise called
malar
as malar rash.
rash.
Patient had one more specific skin lesion, hard palate erosion.
Oral
Then we had a non-specific skin manifestation in the form of palmar lesion.
was present.
Okay. Next.
And diffuse hair loss was also present.
Hair loss was an important thing. Another thing, asymmetrical joint involvement.
Joint involvement. Sir.
So all those things made you to think, okay, I am dealing with systemic lupus erythematosus, isn't it? Now,
yes.
Next. So how do you prove your diagnosis? Next.
So we performed certain investigations. First,
before showing the investigation, you tell me as a student, now you have made a diagnosis. So how do you prove your diagnosis? Then you have to tell what you want to do. Then you show me the results.
We prove our diagnosis, first history, clinical examination.
That is over now.
Yes, sir. Then we carried out investigations like routine investigations, which include...
There is nothing like routine. 1 minute. Always don't tell anybody routine. Even if you do CBC as a routine. So tell me the points in CBC which are going to help. Don't show the result. Show me later.
Sir.
Doesn't matter.
Yes.
If you ask CBC, what you would like to see in the patients?
Sir, in CBP, we will like to see hemoglobin, WBC count, and platelet
One is
count.
hemoglobin.
Yes, sir.
Yes, all the counts of the cells.
Yes,
platelet count, is it important
counts.
or not?
Yes, sir. All the counts, as it might present as panocytopenia. So we will see hemoglobin, WBC, and platelet.
Is ESR important or not?
Yes, sir. Both ESR and CRP are important as
ESR, how it is important? Tell me.
Sir, prognostic value it has.
No.
Disease
I will tell you. His ESR was 30. Is it good point to consider, or is ESR is 100?
100 is
more. poor prognosis with 100. Matlab
No, don't
activity,
worry about prognosis.
activity is
See,
more
one of the
disease activity.
madam, one of the indirect evidence of collagen vascular disease or a chronic disease is raised ESR. There are only 3 conditions which you should think in India. If the ESR is more than 80 or 100, for example, one is tuberculosis, an infective disease. Another is collagen vascular disease. Third is malignancy. So a baseline ESR is important. Then what you are telling, if you do ESR also, okay, reduction would say that, okay, we are trying to see the prognosis, isn't it? One is CBC. Next, what do you want to do?
Sir, after CBP, it should include both CBP with ESR and CRP. Then
That's
liver
all.
function
Next.
test and renal function test we'll perform, sir.
Okay,
In-
those are important or simple? What you are telling routine urine
Sir,
examination is
those are
important.
important.
Huh?
Sir, those are important, sir. In liver function tests, we'll see mild elevation in liver enzymes like SGOT, SGPT, and alkaline phosphatase, and albumin levels will be decreased if renal involvement is there, as we can see proteinuria.
Okay, what else? What else? Other than this CBC urine you have done. Next.
Urine examination we will do, sir, to look for RBC
What
and
I will do,
RBC.
I will, 1 minute. I will ask, draw some blood and see that
LE
any
cells,
test we
sir.
can do.
LE cells we
cell
can
phenomenon.
demonstrate. LE
What is
cell
LE cell?
phenomenon.
What is LE
Sir,
cell?
LE cells are neutrophils containing engulfed nuclear material from the
Containing
dead.
neutrophils engulfing
Neutrophils
the.
engulfing the nuclear material, sir.
Oh, okay, right, good. LE cell phenomenon. That's fine.
Yes.
Next, what else you want to do?
The blood may RFT, LFT, this and LE cell.
Leave it.
Then
They
urine
are all
exam.
RFT, LFT are.
20, sir, in urine examination,
They are-
24-hour urinary protein and
unless
spot
they
urine
are directing
creatinine
you
ratio.
to say that, okay, organ involvement is there. Otherwise, okay, isn't it? Next.
Sir, 24-hour urinary protein and urine
Okay,
protein
next you want to
creatinine
rule out
ratio.
renal involvement. Next.
Renal involvement, sir.
That is over now. Next.
Sir, chest X-ray we will do ECG and 2D echo to rule out pulmonary and cardiac involvement.
Okay, all those things. Next.
Yes, sir. Then we will come to serology, sir.
Come to serology first, after the CBC, all those things, because I will tell you why later. If you
After
see the 1 minute, I will tell now only. All the 4 classifications since 1982, whatever has been done, okay, the ANA criteria was the last one in all the 3, except the latest one, 2019. ANA positive, it is the entry point for classification or diagnosis. So whole scenario is changed. Now you have to do an ANA. First, okay, you are in an OPD and you are suspected, you would like to write ANA screening or only whole panel or only ANA screening?
No, sir, only ANA titers by IIF we will advise, sir. If it is raised and we suspect a particular connective tissue disorder, like in our case SLE, we'll do anti-Smith and anti-double-stranded DNA.
So the first thing is only do screening.
First only
Never
titers.
do whole
Yes,
panel has
yes.
need not be done.
Yes.
Okay. Next, show
So-
your things. See, idea is when you make a diagnosis in an examination, you say, I have made a diagnosis of psoriasis, for example. Leave about this. We'll ask, how do you prove yourself? Then you say, I will do biopsy. Then what do you find in biopsy? Those things should be told. No, how do you prove is these are the things.
Yes, sir.
And
Biopsy.
in investigation also, there are various other things like investigation to prove the diagnosis or to disprove the diagnosis. Investigation as a baseline for giving some systemic drug, because we need a baseline of all the investigation so that we can administer the drug, because over a period of time, if there are any side effects associated with those drugs. So investigations also in 3 categories: to prove diagnosis, to say it is not the diagnosis, negative test, and then investigation for management purpose. Isn't it? Okay, next. So what are the positive things only you tell?
Sir, in blood workup, we saw pancytopenia as all the three hemoglobin, WBC
Yeah,
count and
understood.
platelet
Pan
counts
means
were
all. You did not tell everything.
ESR and C-reactive protein were elevated, and proteinuria, albumin
Okay,
levels
leave
were
it.
decreased.
Next.
On complete
24
urine
hours.
examination,
Next.
albumin was seen on
See here,
24.
1 minute. Here I need go back. Urine. So what is more important in if you send a patient for think that this patient is admitted, she will come after every month, which is the important investigation you should do for this child, 22-year-old adolescent rather.
The 24-hour urinary protein we will look for.
Just do urine microscopy for the cast. That itself
Yes,
is enough.
RBC is cast. We will look to
For everybody you do
glomerulonephritis.
24 urinary, how can it be possible? Isn't it? Initially, we have to do only the cast, microscopy for the cast. That will speak whether patient is gone in for
glomerulonephritis
or whatever. Next. Some basic knowledge is enough. Otherwise, rheumatologists do it. But you should also know what is to be done and then tell them, sir, this is what. Then there will be multidisciplinary approach. Okay. Okay, these are already you are told. Now you tell about this. What are those positive things and how does it help?
The first we'll do ANA titers by IIF. In our case, it was found to be 1:160 in speckled pattern. And
if the case was 1 minute, if the case was done, ANA was 1 in 1, not 1 in only 40. Do you take it as a positive thing?
No, sir. As an entry criteria, it should be more than 1:80, sir.
Okay, good. Next.
So then anti-Smith and double-stranded DNA was positive in our case. Rests were negative, sir.
Okay, why did you do complement levels?
So complement levels is a marker of activity of disease.
No.
And
If
renal,
no,
to rule out
I'll tell you. Okay, those things are allowed. Given the situation, for example, the age of the patient is 22. If it is still less, maybe you are seeing a 10-12-year child with lesion suggestive of lupus. Then it makes sense, complement levels.
Yes,
are there any diseases where?
Homogeneous complement deficiencies.
Complementary deficiency.
Disorders
in children, especially primary immunodeficiency syndromes, you can get the SLE-like lesions or SLE-like lesions with complement deficiencies also, isn't it? Okay, next. So you've done a histopathology. What did you see in this? Most important thing which you should see?
The interface dermatitis, which we saw as it showed vacuolar degeneration in basal cell layer with apoptotic
Word
agents.
interface dermatitis is enough. Don't have to explain all those things.
Yes.
If you want to any perivascular infiltration, sounds little better. Other than interface dermatitis. Okay, right. Next.
Next, we did Euler criteria scoring for our case. Entry criteria was satisfied as it was 1:160, and other features which were positive in our case was fever, thrombocytopenia, as we have to take the highest possible point in each domain, and mucocutaneous, acute cutaneous lupus we took as it showed malar rash over face, and musculoskeletal, more than 2 joints were involved. Proteinuria more than 0.5 gram per 24 hours was present in our case. And immunological domain, complement low C4 level was seen in our case, and double-stranded DNA antibody or anti-Smith antibody, anyone we have to take, that was present. So total score in our case was 31, which was more than 10. So it came out to be a case of SLE. Systemic lupus erythematosus.
Okay. If you have taken only ACR criteria.
Yes, sir.
Okay, how many criteria should be there instead of score? How many criteria should be there to diagnose suspicion of SLE?
More than 4 out of 11, sir. More than or
Any
equal
4.
to. Yes, sir.
Yes,
Any
sir.
4 of the 11.
11,
Yes.
sir.
Okay. If it is SLIS criteria,
In
Seven-
SLIC,
17 out of
4 criteria, but one in immunological domain and one in clinical domain should be present.
4 out of 17, sir.
if it is directly histology compatible with
Yes,
lupus
sir.
nephritis,
Biopsy
or
program
ANA or
lupus nephritis.
NTDS DNA, or any 4 of the 70, and at
Yes.
least one
One
immunological
clinical,
criteria has to be there. The idea of asking all these things is you must know why these developments of ACR, SLIS, EULAR, ultimately we want to be more specific for the diagnosis and scoring system. Okay, so that has to be found out. Anyway, you have done it, and 31 is your point. Next. Okay, this is the diagnosis.
Yes, sir.
Again, confirm. So
Yes,
final
sir.
diagnosis you should write.
Final diagnosis was systemic lupus erythematosus and RP.
Okay, now you have diagnosed the case of an young female, 22-year, unmarried. How do you treat this patient? I won't use the treat. How do you manage is the better word, because one-time treatment is treatment actually. Only infective conditions you can do.
So management, first we should provide general measures like sun protection. Sun protection can be done by advising patient
No,
to
you should ask first occupation of the patient. If you want to tell sun protection, is it not important?
Yes, sir, it is
If
important.
she is a young girl, if she is nowadays, all these young girls or the young boys will have software engineers or somebody who works continuously in front of the blue light. So planning strict sun protection is not just telling don't go to sun, isn't it? So you have to ensure first ask the occupation. If it's a lady who works in a farm labor, how should she protect? Like that, there are issues which you should sort out by asking occupation. One is strict photo protection. Next.
The strict photo protection, then basic measures like proper nutrient supplementation, and
Those
then
things, don't worry.
Then we'll come to the treatment part. Topically, we'll advise patient to apply topical steroids over the lesions.
What are the
Topical-
indications of topical steroid in face lesions?
Sir, if the lesions are thicker, plaque-like, then it will DLE-like lesions. Then it will thickness will reduce, and it will reduce the inflammation also, sir. In case of active disease.
If it is already patient has come with, we are discussing DLE lesions or the face, for example, already they are atrophied. One of the definition is atrophy. Central atrophy will be there, isn't it?
Yes, sir.
With thick adherent scale. So do you
Yes.
still prescribe
No, sir,
steroid
then we
or
will
any other molecule?
tacrolimus and primicrolimus we will prefer in that
You should
case. Sir.
tell topical calcineurin
Topical calcineurin
inhibitors.
inhibitors, sir.
Okay, isn't it? Okay,
Mm.
next. Next, what
Then-
do you want to do?
Then after topicals, if the lesion is more thick, if
Okay.
lesion,
She tells, I want a prescription of sunscreen. Which sunscreen you would like to prescribe?
the physical sunscreen which should cover all the 3 spectrums, UVA, UVB, and visible light, sir.
Okay, that means I want an answer. Means
Broad spectrum.
physical sunscreen is a better one.
Yes.
Okay. If that is the case, she tells her, when should I apply? My office timing is around 9. So you
Yes.
have prescribed a physical sunscreen. When you will ask them to apply?
Half an hour before, sir. Like 8:30 she should apply.
Why? Then you have not understood. Physical sunscreen you can apply as soon as when you start only. Only chemical sunscreen you should apply half an hour before. If I'm correct. If I'm wrong, you can correct me also. Isn't it? Okay. Next, sunscreen, by asking occupation, how do you plan it is very important. It is not that just Professor Sitaram sir write 9, 12, 3. Every
Yes,
3
sir.
hours you should apply. But if the person works at night, work from home, then in front of a blue light, you have to add even iron oxide containing
Zinc
sunscreen.
and iron oxide.
Okay. This is the idea. This is how you have to plan the treatment. It is not that book is strict for tell, don't go in sun.
Yes,
And then
sir.
apply the sunscreen. Then you will apply Himalaya sunscreen. Okay. Next.
Sun protection topical if the lesion is thick, intralesional
Okay.
steroids.
Madam, I'm asking in this patient now.
Yes, yes, sir.
20-year-old, already
In
you
our
have
case,
diagnosed.
yes, sir. In our
Our
case,
case
since
only.
the
Always
disease
case
was,
is.
since the disease was active, we started her on oral corticosteroids and HCQs. Oral corticosteroids will reduce the inflammation part. First, we'll
How much you
study
give?
0.5
Patient will
to
not
1 mg.
understand that. Huh?
Sir, we gave at a dose of 20 mg as we have to give around 0.5 to 1 mg per kg we have to give. In our case,
What
we
is
started with 20
1
mg.
minute, 1 minute. Here I will discuss. What is low dose steroid and what is high dose steroid? What is the dose schedule for low dose means what? High dose means. You want to use low dose or high dose in this?
Sir,
There are
low
certain
dose.
conditions we do right high dose. Anyone in books we mention.
Sir, high dose we'll use in psychobullous disorders like
No.
Pemphigus
Tell
vulgaris.
me the dose.
Point,
Patient will
0.5
not
to
tell.
1. 0.5 to 1 mg per kg.
This
1
your
to
friend is
1.
telling, he is not telling anything.
Sir,
1
1
to
to
1.5
1.5
mg per kg.
If I am correct, 0.3 to 0.5 is low dose. 1 to 1 milligram per kg to 2 milligram is high dose.
High doses.
Sitaram sir saying yes, then I will go ahead.
No, yes, sir, please.
Okay. Okay. So that means you want to give this much because it was more acute in onset. You thought steroid will take care the inflammation. That is very good simply because the best, the pan-immunological suppression is steroid only. Otherwise, whatever you're doing, T cell, B cell, T and B cell or target like that, isn't it? Well, then next. Again, remember, 22-year-old female. You should plan this treatment. Okay. So you give steroid.
Yes, sir.
How
Low
long you will
dose
give?
Sir, till the disease activity subsides, and we'll start her simultaneously on HCQs. Till the HCQ action takes over, we will taper the steroids slowly.
Okay. What is the dose of SCQ you want to give? What is her weight?
Sir, her weight was 55 kg, sir.
That you are not
And
done. I know. Okay.
we'll give dose we should prefer is less than 6.5 mg per kg. And
No, that is what you are telling old. That's why I'm asking.
recently they told to be less than 5 mg per kg according to American Society guidelines.
Earlier one was 6.5 milligram
6.5
per kg body
kg.
weight to the maximum of 400.
Yes.
Isn't it? Okay. Now it is 5 milligram.
Less than 5, sir.
Okay. Did you just start like that or did you do any
Sir,
other department examination was done?
Sir, ophthalmic evaluation will advise patient.
Did you do it in this?
Yes,
patient?
sir, we did, sir.
Okay. What you will see in ophthalmology? What they will see? What
Sir,
is important when you want to administer hydroxychloroquine?
So fundoscopy and visual acuity testing we should do, sir.
How visual acuity is test done?
Visual activity is tested by asking the patient to read the Snell's chart.
Okay.
And
just anyway,
fundoscopy.
see, I know you, when you ask, see the cross reference and all, you should know minimum what they will do. Isn't it? Now you read it and later you can mail me what was done. Don't worry, but this is what has to be thought. This is a mock examination where what is to be, even later when you become consultant, you should know what they do it also. Minimum, not that you should study AMS ophthalmology. Isn't it? So chloroquine you want to give. That also you have added. Okay. Again, remember unmarried 22-year-old. So what other than these things like steroid and these things, what anything you want to add to this patient? You are giving for a prolonged period steroid.
Calcium and vitamin supplement.
some calcium supplementation is
Hmm.
fine. So now the
Calcium and
question
vitamin
is,
D.
yes, now the question is, how long you will give? Every time what you will see to say that whether the activity of the disease is there or not.
Sir, HCQs we can give long term. Baseline we'll do the ophthalmic examination.
That you have done already.
Then
Next.
we'll repeat the examination, ophthalmic evaluation after 6 months, and then after 5 years, and then yearly after 5 years,
That
sir.
is okay. Now you are taking care. You are a good doctor.
Then disease activity scoring we will see, sir. Disease activity scoring we can assess by, there are three major
No, my
scoring.
question is, see, clinically, how do you assess the activity of the disease? And
Sir,
then,
malar rash. Sir,
Hmm.
subsiding of the malar rash, photosensitivity, and oral ulcers we will see, sir.
Okay.
If oral ulcers subsided and malar rash subsided, we will
Malar rash subsides easily.
yes.
Oral ulceration or ulcer is the most important clinical finding by which activity of the disease is
Yes.
found out. So you must see every time the hard palate, what has happened to its size, whether it is healed or not. Even if it is slight increase in size, well, you are doing it. And another way which this is one thing clinically.
Investigation. Sir.
Investigations.
Investigation. Sir, disease
Simplest
activity.
is ESR. Another is urine microscopy.
Yes,
Okay. Now
Yes,
question is whether the serological test help in assessing the prognosis of the disease or the
Sir,
activity of the
anti-double
disease.
stranded DNA will help in prognosis. ANA won't help. ANA is not a prognosis.
So
Anti-double
don't
stranded is a
keep on,
prognosis.
never repeat the ANA again and again. Once positive and you have made it a entry point diagnosis, that's enough, I believe. Okay. Now, again, I'll repeat. Now she is a female. She wants to marry because 22-year-old. Now, how do you plan her treatment now?
Sir,
It is a
if
special
she,
situation now. One is
Yes.
lady, unmarried. Now she is going to get married.
yes, sir. Sir, in case of pregnancy, disease should be inactive in the past 6 months. Then only we'll advise her to conceive, and no renal involvement should be there. If renal involvement is there, pregnancy will be complicated, and there will be chances of eclampsia and preeclampsia. And we should rule out Apla syndrome also, as it will complicate the pregnancy. And also we will tell the patient regarding the chances of getting neonatal LE. In case of first pregnancy, chances of neonatal LE is 25%, whereas in case of subsequent pregnancies, it depends on previous pregnancy. If the first pregnancy is positive, the chances will be 36%, whereas if first...
Wait. Don't tell theory. Sir is not asking theory. So you are trying to just, whatever you are by-hearted, you are trying to narrate. Just listen to his question and then answer it. Whatever you know, we don't want everything. We know that you have read it very nicely, but no, that is not his question.
Counseling the patient.
Treatment. How are you going to plan her treatment further? We have told 2 drugs now.
HCQs and steroids can be continued.
What else you can give to her if she develops any other complication of renal system? You look for and what will you give? That's what sir is asking. He is not asking everything theoretical now. Practical questions sir is asking. Answer
Sir,
that.
We'll counsel the patient. Next, we can start the patient on steroids and HCQs in the initial 6 months.
What else you can do for her? Any other drugs which can planning? That's what sir is asking.
Azathioprine can be given, sir, by doing TP.
That means you want to give some steroid sparing agents.
Yes,
if
sir.
you want to stop the steroid, and HCQ has to be continued.
Yes,
so
sir.
whether HCQ can be continued in pregnancy or not, number one.
And can be continued.
Okay, that means you have to tell the patient that, okay, even if you get married, pregnant, this drug is an important drug. It has to be continued. And then which drug can be given? For example, pregnancy can exacerbate SLE, isn't it? So what you can add in that case?
Which drug can exaggerate?
Yeah, if they say SLE is going to be increased in pregnancy, what other drugs you can give?
Sir, HCQ steroids, and in case of APLA, if it is there, then
No APLA. SLE is increased. APLA you
cyclo
have not done. What other drugs you can give in pregnancy?
azathioprine we can give, sir. Dapsone also we can give, sir. Azathioprine, Dapsone we can give.
Pregnancy
Whereas
azathioprine. Anything else?
biologicals we can try, sir. Rituximab and TNF alpha inhibitors.
Rituximab we can try.
Yes, sir.
Can you give mycophenolate in pregnant patients?
No, sir. Mycophenolate mofetil is contraindicated in pregnancy.
Azathioprine can be given.
Azathioprine can
Given,
be
sir.
used.
Okay. What is her course of the disease now? What will happen if you treat, if you do not treat? That is, in textbooks, when you read the chapters and all, at the end, there will be course of the disease. So that you should read always, because many a times when you treat, for example, I will tell you, lichen planus, you treat, and within 6 months you will come again, sir, it has gone, again come. So if you read it properly, you tell up to 2 years it can come. Isn't it? I'm just giving you one example. So what is the patient will ask, is a young girl, no? She will ask, क्या होता है आगे? What will happen to the disease or for me?
So prognosis, disease can anytime flare up, but if the patient is continuously on HCQs, which we are giving long term, we can reduce the episodes of recurrence.
If
Okay.
no systemic involvement, mortality will be less. So we'll counsel the patient. If there no systemic involvement, mortality will be less.
One is regular follow-up. Always look for mortalities which are associated with lupus nephritis. That has to be. And lupus, especially psychosis, will be more after post-purpureal thing also. So you should look into that aspect also when you treat them. Isn't it? Okay. Do you want to use any JAK inhibitors in these patients? There is
Yes.
arthritis
Yes.
also
JAK.
added point.
Ustekinumab and
JAK amma ustekinumab.
tofacitinib can be used, sir.
Okay. Right. Sir, anything?
Okay, if you have completed, then we will take up questions from the.
Yes.
Plenty of questions are there.
That only water really. It's not a Viva. Just wanted something.
Yeah. That's no. It's good. You are telling Dhruti neonatal LE. So
Yes, sir.
tell me how will you see them in diagnose the neonatal LE?
Sir, for diagnosing of neonatal LE, clinically, lesions will be more common in the face and scalp region, and photosensitivity will be present. On serology, we will see anti-Rho and anti.
Neonatal LE, how does it present commonly? Is it skin or is it
Periorbital erythema with mild raccoonitis will be seen.
Sir, periorbital erythema will be present, and
what is the most
photosensitive.
complication that can occur?
Sir, congestive heart block will be present, sir. Congenital heart block, which is irreversible, will be seen. Which
It occurs, is it reversible?
No, sir, it is irreversible and can be treated only by applying pacemakers.
Okay. What is the normal course of neonatal LE? What will happen?
It will resolve spontaneously, sir, in most of the cases. With mild
Mostly it will resolve, sir. Very few cases can progress to LE cutaneous.
Most of the time.
Very rare. Mostly it will resolve spontaneously within 6 weeks.
We are talking always APLA. What is this APLA?
Antiphospholipid antibody, sir. We have to
Do
suspect.
that? Do you do that in all cases of SLE?
No,
Or
sir.
do
We will
you
suspect.
clinically look for some findings and then history or findings and then you do the APLA?
Yes, sir. We will see recurrent abortions as Sir told, and then next is thrombosis, history of thrombosis, and in cutaneous findings, we will look for cutaneous features such as livedoid vasculopathy, livedo reticularis, atrophic blanche, DJOS-like lesions, and ulceration, which will suspect us towards APLA.
So what are the components of APLA?
Sir, APLA contains 3 components, which include anti-beta 2 glycoprotein, lupus anticoagulant, and anticardiolipins.
So Subhashini, if you have questions, please come up.
Okay, sir. So, types of hair loss in LE patients. Nagendra Kumar from New Delhi asked.
Hair loss can be both cicatricial and non-cicatricial. Cicatricial is mainly seen in case of DLE, whereas non-cicatricial can present as diffuse hair loss, lupus hair which are short, unruly, close, fragile hair seen mainly in the frontal hairline. And next, alopecia areata can also be seen.
Do all connective tissue disorders have any common immunosuppressive drug?
Corticosteroid is an immunosuppressant which can be used in all connective tissue disorders. Next, methotrexate, azathioprine, and cyclophosphamide. In case of renal involvement, MMF will be preferred, whereas in case of pulmonary involvement, cyclophosphamide is the more preferred term.
Why can't you give methotrexate in case of pulmonary involvement?
Methotrexate, pulmonary fibrosis.
Okay.
What are the indicators of disease activity? I think SLE disease activity.
Already discussed, I believe.
ESR, double-stranded DNA, and complement levels are also indicators of disease activity.
What is a TART cell?
TART cell.
Neutrophil in which fragmented dead nucleus will be.
It is a type of LE cell only, but neutrophils fragmented nuclear material will retain its properties. It won't mix and homogenize in TART cell, as in case of LE cell.
What are the factors which indicate conversion of DLE to SLE?
First is age of the patient. If age of the patient is less than 40 years, in case of disseminated DLE, and in case of elevated ESR, elevated ESR. And leukopenia also. Elevated ESR, leukopenia, age less than 40.
What is bullous SLE?
Bullous SLE here, clinically, the bullae will be seen both on sun-exposed and sun-protected areas. And on histopathology, subepidermal bullae with neutrophilic infiltration will be seen. On DIF, there is linear immunoglobulin deposition along the DEJ will be seen. And on serology, along with this, ANA will be positive, dsDNA complement, dsDNA, ANA will be, ANA titers will be raised, dsDNA will be positive.
Dr. Fernandez from Panaji asked, what is SLIC criteria?
In SLIC criteria, there are 17 criteria containing 11 clinical and 6 immunological criteria, which clinical criteria includes acute cutaneous lupus, chronic cutaneous lupus, oral ulcers, non-scarring endoplasia, and systemic like synovitis, serositis, renal involvement, neurological involvement, and hematological components, whereas immunological components includes ANA titers, anti-double-stranded, anti-Smith, complement, low complement levels, and direct Coombs test. In any 4 criteria, which should include 1 immunological and 1 clinical criteria. If positive, then we'll consider the case to be SLE or biopsy-proven lupus nephritis with double-stranded DNA or any.
Stop your screen, Dhruti. Subhashini, if the questions are not there, Professor Alina will give us a small talk. So regarding CTDs, so
How to approach?
20 minutes, yeah.
I can
Sir,
share that.
you have to give the approach or
How to approach?
okay,
The small one.
yeah.
Okay, it was nice to be as examiner. Anyway, I have too learned many things. And I thought a small presentation of how to approach collagen vascular disease would make more sense once we discuss a SLE case actually. Okay, connective tissue disorders or multi-system diseases that share several common clinical features with a strong immunological underpinning. Anti-nuclear antibody are the primary screening investigation. But very important point is the mere presence of ANA does not confirm connective tissue disorder, and conversely, the absence of ANA does not rule out connective tissue disorder. The classification criteria are essential for research and epidemiological purpose. The utility of classification criteria in routine clinical practice is limited, since classification criteria are not same as diagnostic criteria. The classification criteria are adjunct to and not substitute for rational evidence-based clinical judgment. What is more important whenever you deal with collagen vascular disease is the delineation of organ involvement is more important than diagnostic levels. Why? Organ involvement governs the treatment decisions. The treatment takes into account the disease activity at that point in time. Then how do they present all these clinical, the connective tissue disorders or collagen vascular disorders? They can mimic a serious infections, something like acute severe illness. They can have an insidious onset of disease with gradual accumulation of symptoms and signs over weeks to months. And most important point is the presence of multi-system involvement. Evidence of inflammation and lack of any obvious cause should alert clinician to possibility of connective tissue disorder. So presentation can be acute, insidious, multi-system, or inflammation, but you don't find any known evidence for that inflammation. Most important thing is history is photosensitivity in both LE and dermatomyositis. A lot of vascular sequences, especially the vasospasm, which causes Raynaud's phenomenon, and non-specific manifestations like purpura and ecchymotic disease, ecchymotic lesions. And another important is the muscle weakness, especially the proximal muscle weakness history. And most important as a dermatologist is the skin and mucous membrane lesions, which can be specific and also non-specific skin lesions. And there can be hair and nail changes also, and other system involvement are usually system specific. As far as presentation of SLE is concerned, already we have discussed in depth. Dermatological manifestations like malar rash, photosensitivity, discoid lupus are very important. And more than 80% of the patients with SLE suffer from mucocutaneous involvement. And one of the most well-known and identifiable clinical features are always skin one. The SLE skin lesions may be a lupus specific, while several non-specific lesions can also be there. Then how the presentation of scleroderma? Well, you have got cutaneous pruritus, which is very common. This you should keep it in mind. Many a times we do not think any old age patient coming with pruritus, we think, okay, some senility is there or winter dermatitis if he comes in winter. But we have to touch the patient, find out whether any evidence of thickening of the skin is there or not. And another presentation is Raynaud's phenomenon. And even difficulty in swallowing the solid foods, shortness of breath or exertion, and joint pain, limitation of the movement, joint swelling, muscle pain also be present. But invariably, the systemic sclerosis begins as in 15% of the patient as a joint pain, and inflammatory myopathy in 10% of the patient. A weakness is present in 80% of the patients. The skin involvement is the most overt feature of systemic sclerosis and is present in almost all patients with systemic sclerosis, varying degrees of severity. You can start with puffy finger phase, prolonged fibrotic phase, and finally you get skin with softening phase. You will get telangiectasis and also subcutaneous calcinosis. So the presentation of limited systemic sclerosis is Raynaud's phenomenon is a starting point. And then in 5 to 10 years, you get swollen fingers, sclerodactyly, GERD, telangiectasia, calcinosis, and minimum ILD. So by the time you see all this, already 5 years or 7 years must have completed. And at the end, it is the pulmonary arterial hypertension, which is going to be an important point. And as far as the diffuse SSC is concerned, initially there will be Raynaud's, progressive skin thickening, GIT involvement, arthritis, fatigue, and antinuclear antibody positivity. And within 5 years, the patient may develop severe ILD, renal crisis, and at the end, again, pulmonary hypertension. As far as presentation of dermatomyositis is concerned, cutaneous involvement may manifest sole manifestation at the onset in perhaps as many as 40% of the fellows. That means many times you don't find the myositis component, but cutaneous involvement is very characteristic. They are all eruptions predominantly on the photoexposed surfaces. Pruritus of the skin lesions, sometimes intense enough to disturb sleep. This is an important point to differentiate between photoexposed lesions in SLE and dermatomyositis. Erythema of the midface, eruption along the eyelid margins, eruption on the dorsal hands, particularly over the knuckles, which we will know as a sign. And then change in the nail fold of the fingers, eruption of the upper outer thighs, scaly scalp, or a diffuse hair loss. Even sometimes itchy scalp is a presentation of dermatomyositis. Muscle involvement, all of you know. And then what physical examination when you want to do for connective disorders is, one is skin lesions. Why? Because there are indicators of the disease activity in systemic lupus erythematosus, just now we discussed. In a mild disease, patient with only one type of lesion will be there. An intermediate disease activity with 2 different lesion types. Lupus-specific skin manifestation serve primarily as an important diagnostic clue. So these are the few things which I would like to show here. The localized radial lesions, which are very classical, thick scale, adherent scale, which we demonstrate as carpet tuck sign. We also call this a tin tack sign, cat tongue sign. I was really perturbed with remembering these things as a PG. What is tin tack? What is cat tongue? I had to really literally see the image in the Google. What is that cat tongue sign? But so I devised an easy method by which you can explain this simple technique to explain carpet tack sign, which we even reported in the Journal of American Academy of Dermatology. Just take a paper, punch, perforate with the paper with a little hard pushing, and reverse of that, what you see is the carpet tuck sign. Why? Because the hair follicle extension, follicular extension of the scale is carpet tuck sign actually. So this is how we can, sometime over a period of time, if you experience the difficulties, you'll find some solutions which are easy to remember and understand the disease. And what is more important, however severe lupus erythematosus is there, sparing of the nasolabial fold will be there, and that is the important point in diagnosing very severe diseases where you may not be able to find other things as a diagnostic clue. And butterfly eyes, which we already discussed. And one more important point, if you find DLE lesions in SLE, like what I have seen in this, what I have shown in this picture here, in 25% develop such lesions will have less severe form of SLE. That means renal involvement is not seen. That means by just looking at DLE lesions in a LSE patient, you can predict that the prognosis is good simply because renal involvement is not seen, isn't it? And we discussed good amount of oral ulceration. I always make it a point to see the hard palate in all SLE patients once in diagnosis and also later whenever there is a follow-up, simply because they indicates increased disease activity. So look at oral ulceration. You have done a great job in following up the patient. And there was a question, hair changes 3 types. One is diffuse alopecia, lupus hair, and also scarring alopecia. And the doctor was telling about alopecia areata. As an autoimmune disease, you can get an association. Otherwise, very classical changes are diffuse alopecia, lupus hair, and scarring alopecia. The pictures are self-explanatory. I need not tell it. Why it is important is it's a commonest non-specific cutaneous feature in more than 60% of the patients. So don't just neglect this type of hair losses. Then face, especially these are thing in progressive systemic sclerosis. Early sign is wax-like wrinkle-less face, ingram sign, overcrowding of the teeth on the jaw, perioral purse string head regates, pinched nose, mat-like telangiectasia, salt and pepper dyspigmentation. So just look at the face. You get a lot of things in systemic sclerosis. And then hand changes, already we had told, puffy finger, then you got non-pitting distal edema, then the rapid sclerosis. This is the advanced sclerodactyly, where you get atrophic face, small pointed fingers with hide-bound sinus skin. If somebody asks what is sclerodactyly, this is the definition actually. Okay, and then already we have discussed Raynaud's phenomenon, cold or emotional stress, and even what is more important in severe Raynaud's, ear nose may also be seen with this color changes. This has to be a point, extra point, which you should remember. And then proximal sclerosis, which you can by touch, you can find out. And sometime I was discussing about the palmar lesions in the SLE patients, which they showed actually. That can also be palmar telangiectasia in scleroderma, and also the loss of fingertip pulp, which looks like beaked appearance. Okay, and then these are the distal pitted scars. Initially, what happens? There will be pitted, only pits will be there, distal pits, and then becomes ulceration. Then they become scar. Why? Because it is repeated and increasingly severe attacks of Raynaud's phenomenon, which lead to fingertip ulceration, leaving pitted scar or a star-shaped scars, which I have shown you typically. So they explain the pathogenesis, why it happens, by just looking at the lesions or the tip of the digits. You can say what stage the patient is, isn't it? And then, well, all of you know about this, the capillaroscopy, which you should be able to do regularly. And then calcinosis cutis, and then heliotrip rash characteristic feature. And whenever the preferential involvement of the upper eyelid, it reflects activity of the myositis, severe activity of the myositis. And these are very classical Gotton's papules, which are pathognomonic features. What do you find? Have anybody tried any time? There will be telangiectasia in papules. This has to be differentiated because sometimes knuckle pads can be seen like these thick lesions over these areas. So if you can demonstrate telangiectasia, well, you are with the Gotton's papules. And dermoscopy of the nail fold in DM, we have got periangular telangiectasia, risk of Raynaud's, pulmonary involvement, and arthritis. If you find periangular telangiectasia, you can predict there is possibility of pulmonary involvement and arthritis is more in case of dermatomyositis. So simple things will give you a lot of clues. And some diagnostic criteria, well, usually clinical and features like malar rash, Raynaud phenomenon, Gotton rash, all these cutaneous manifestations suggest a possibility of connected disorders. But presence of autoantibodies like ANA, anti-DS DNA provide supportive evidence to diagnose the CTD. Well, there are various criteria which have already been discussed. SLIS, what I would like to highlight is SLIS has a sensitivity of 94 and specificity of 92. But over a period of time, we keep developing the various criteria to simplify and to make it more specific and more sensitive also. Since in 1982 ACR, then 1997 ACR, then SLIS 2012, EULAR ACR in 2019. We have developed these criteria so that we improve our diagnostic possibilities. And especially when you want to, as the discussion was on SLE, ACR, any 4 of the 11, SLIS already discussed, and 10 points if it is EULAR ACR. And sometime in dermatomyositis especially, the antibody also speaks something else also. For example, if it is a MDS antibodies, then there will be skin ulcers, palmar papules, and mechanical hand. And they will have more ILD and less muscle involvement. That means the antibodies also speak what type of clinical manifestations will be there, or the other way around, as a skin specialist, we can say that, okay, mechanical hand, you have got more ILD and more muscle involvement. By just looking at the skin lesions, you can say severe skin eruption, calcinosis, less Gottron signs, ILD is less, chances of cancer are more, chances of muscle involvement is more. So these type of charts also help you to understand why, as a skin specialist, is important in rheumatodermatology or rheumadermatology, which I call, and your role is very specific, that you are the first person to see many things. You can guide them, direct them, and prognosticate the patient, and you can be an effective first contact physician. Okay, how do you interpret ANA is one thing, these patterns and all. Something like this type of chart, you should keep it with you whenever there is a positive thing, associated skin and joint involvement, what the antibodies will be there, what will happen. So these type of flow charts are very important. I don't want to go into the depth of each one. You should keep it with you always in your table so that you can easily explain everything, isn't it? To conclude, the collagen vascular disorders are multi-system illness with marked cutaneous involvement. They have overlapping clinical pictures and mimic other illnesses, and they can be life-threatening complications. So why, as a dermatologist, we should know? Most of the time, the presentation with skin manifestation come to us, and we have to have a minimum basic knowledge how to interpret various the tests which we do, and what minimum basic treatment we must start, and what best we can have with the multi-speciality involvement also. So learning collagen vascular disease, something like learning whole medicine actually. So hope this is just a small presentation by which you can understand how important is this session of presentation. Thank you, sir.
Thank you, Dr. Anand, for a wonderful discussion. So I told them, sir will be asking only on the clinical parameters. So, so this is very important to know each clinical finding, why it is there, why it is not there, what you should know. And that's what exactly you brought it out, which is very, very important in any case. So nice of you. Thank you very much for spending your time and giving us a overall view of the collagen disease also. And your discussion was excellent. I hope every postgraduate who attended this will definitely benefit out of this. And thanks a lot. Thank you very much for obliging us first. That's nice of you, sir.
It was again, for me also, it was something like, again, exam going student like thing. I have to just brush up my mind and think like a student, how I would answer or question also, both.
Thank you,
and
sir.
as you rightly told, they read everything, they want to vomit everything, but it is not, the vomiting is not an answer. It is digesting and putting the best food out of what you have digested. So this is what they should learn as a student actually. And whenever a case discussion is there, it is pertinent to the case has to be asked and discussed rather than what is given in book, because patient will not understand what is science. So they understand only, they have faith in you, they have come to you. They will not know what is ANA or what happens to my kidney. So how you explain, how do you make them the quality of life, how we can improve, especially in case of collagen vascular disease. Thank you very much, madam, both Kavita madam and other madam, Saujanya madam, for giving me an opportunity to learn again. Thank you very much. Always I'm grateful to Professor Sitaram sir, and I can't say no to him. So I have joined for this. Thank you very much.
Thank you, sir.
Thank you,
sir.
Dhruti and Tanuj also have done well. Nicely presented the case and the discussion part of it also. So only the point, as sir said, that remember that answer to the relevant question. That's all. So you already people read, especially when it is given such a long time before, even in the exams also, most of the times what cases are going to be there. So the most important thing is you just listen to the examiner what he is asking relevantly and then answer. Don't try to tell everything whatever you know. Next question will come automatically. He will definitely ask you a tough question which you will never able to answer. So just listen and answer to the relevant whatever the question is asked. Relevant answer only to that particular question. And mostly all the exams will ask only the clinical parameters, clinical discussion. How do you manage this particular case? Your case. They don't want theory. Theory everybody will read. So your case, how do you manage? This is very important. Good. You have brought out those things also. That's nice of you. Well, very well presented and very well done. Sir, Arun sir, I just want you to tell about your laser program so that the postgrads.
Yes, yes, sir. It's so nice of you, sir. We at BLD University, we have a collaboration with DECA, an Italian company of lasers, which are globally number 2 or 3, I don't know. We have made an academy wherein there will be some training sessions for postgraduate students and also the dermatologists in their early career, and also the senior also who are already using lasers, the other thing. It is not that it may be surprising to most of you that how Dr. Inamdar is interested in laser. I'm just trying to make a platform for all of you, all my Indian dermatology colleagues, where the best experts of laser in India are my good friends. To name a few, Sanjeev Arangbadkar, Chandrasekhar, or Salim, Shehnaz Arshiwala, Swapnil Shah, many more like this. So they have agreed to be the mentors there. And whenever we conduct the sessions with all possible laser equipments also, we wish to have training sessions and sometime the webinars also, like just a few last month we had to start. Just let's understand what exactly the history of laser or the basic physics and all of things. And by June, probably we are starting similar, the fellowship in laser surgery, laser medicine, especially in relation to dermatology. It will be little different kind of thing than other fellowships, because as a deemed university, we have got every opportunity of starting such fellowships, and the student whomever we select, of course, over the period of time we publish those things with all of you, that those students will be get trained in within a 1 year period, 2 months with one of the mentor like Chandrasekhar, one of the mentor like Sanjeev Arangbadkar. Like that, a student will go 2 months in different places. They will learn practically there, and the other basic things, examination, some course work or the period work will also be done at our places. And we have also made a center of excellence wherein every possible laser equipments are also kept so that they can also do, the practical things also. So it will be a little difficult, different kind of thing. And they will also have a chance to visit Florence for 1 month or at least 2 weeks to 1 month. At least I'm envisioning 2 weeks in the academy at Florence run by DECA. So other than Italy, this is the first of its kind in entire globe, this academy of this kind. Hopefully we'll serve our fellow dermatologists, especially the youngsters who are interested in these type of things. Well, but today's discussion brought one thing. First, let's be perfect in clinical dermatology, and then all these things, bread and butter. First bread, then the butter. But you should know, just because you have butter, for every roti you cannot apply and eat it. So the idea is not because you have got a machine, you just keep applying, but indication and then the machine, not machine indicated treatment. So hope we'll do something better. Our idea is, in fact, I discussed with Dr. Sitaram sir and all, we have to give back to the specialty. So this is how we think we are trying to give. And over a period of time, even this, the rheumatorrheumatology fellowships or training, something of that kind, we are envisioning. Hopefully we'll do it. And the training, I will talk to you, Madam Kavita and your secretary, so that we can plan something of that kind. Even if you want to, about 30-50 people who can come to Bijapur, and have a training of that kind, we'll try to arrange. And by another 2 months, Bijapur will also have a airport, and then the communication, the logistic will be easy also. Okay. Thank you, sir, for giving me an opportunity to explain our little contribution back to society.
Thank you, sir. It was a wonderful program. IIDVL AP is very proud to conduct this program. Today, we had a record of 514 attendees, highest number till now. Thanks to Dr. Professor Arun Inamdar and Sitaram, sir. My heartfelt thanks to you, sir, for briefing over the connective tissue diseases. Your questionnaire and simple explanations are very thought-provoking. Both our postgraduates and practitioners are enlightened, and your presence today is we are very happy with your presence today, sir. I thank our president, Dr. Kavita, for conducting these programs. She's behind these PG clinics. And I thank the postgraduates and Dr. Subhashini. And
Right.
I thank
Subhashini is our associate professor.
Sir?
Subhashini is our associate professor.
Yes, sir. Associate professor, sir. And our postgraduates as well, sir. Today's participants. And I thank Gloderma people for organizing these every month. They have a small presentation, sir, which they would like to play now, sir.
Can I leave the? I have to go to college.
Right.
Don't mind.
Thank you very much.
Thank you, sir.
Thank you, sir. Thank you,
Okay,
sir.
thank you, sir. Thank you.
Thank you so much, ma'am. And thank you all of you to joining with us and for giving an opportunity to provide technical and education support. Stay tuned for next IDVL lecture, which is on 12th March 2024. I would like to introduce about our organization, Gloderma, spreading glow in the lives of millions through innovative technology. We have a pan-India presence, enterprising team of 500 plus professional and path-breaking innovative technology. Also, we have many first-time Indian brands and gain the trust of dermatologists. Gloderma have a patient safety is of a paramount concern, and India's first company to make all products paraben-free, sulfate-free, and detergent-free. I would like to introduce about our flagship brand, that is Moist. The Moist, the most advanced moisturizing and cleanser. We have a Moist cleansing lotion, Moist LMM 48, Moist cream, Moist XL, and Moist Scented bar. Now I would like to introduce about the next brand, that is a Sanosun Baby. We have a tie-up with the Sanosun Baby, which is made in Germany. Germans premium baby skincare, trusted by mothers in 70 plus countries. Gain the trust and confidence of 1,50,000 Indian mothers till now. Also, we have recently launched a Facetinib gel, which containing Tofacitinib 2%. And also we are launch a Crisaborol molecule, that is Crisbotop. Thank you all of you to joining with us. Stay tuned for next lecture. Thank you, ma'am, and thank you, sir.
Thank you.